Alrighty, good afternoon, everybody. My name is Haley Yates. I'm the manager of strategic solutions here at UBA. And on behalf of United Benefit Advisors, I welcome you to today's UBA Employee Benefit webinar, Using Analytics Across the Client Journey. We are pleased to have with us today Hugh O'Toole, CEO from Innovu. So welcome, Hugh, and the floor is yours.
Thank you, Haley, and thank you, everybody that is attending today. I do want to kind of bring you through a journey on how analytics affect you as both somebody advising a client and actually the client, and how it can be used not just for observations, but truly for impact. I'd also encourage you, I said this to Haley, if you guys can ask questions, it will make it far more interesting than listen to me drone on about analytics. I think it will come to life for you. And one of my favorite slides over my entire career, as somebody that's always been committed to transparency, disclosure, process, and how to use data to improve the outcomes for both the employer and the participant, is this slide here. And what I would say is the momentum for the use of data in employee benefits, healthcare, pharma, HRIS, workers' comp continues to accelerate all the time. The reason that is, it's really no different than running any other business. The more data you have, the more you can curate that data, the more predictive you can be, and you'll see how you can actually isolate the issues that exist within your employee benefits so that you can take strategies to optimize the result, both financially, but maybe even more important, the health of the population. So that will be the theme. I would tell you this slide works both for what we do with this great advisor community. It also works in every single business I've ever been involved in. The second ingredient on data is process. So a lot of people these days will talk about a plan sponsor's fiduciary responsibilities. If that word intimidates you in any way, even though it's true, I just would say, what is the right procurement accountability process that we should use the transparency and data that the government is begging plan sponsors to use to improve that outcome? And it really is this cycle. And at the end of this presentation, I'm going to give you a real life cycle based on your plan year on how you'd use process, data, great advice to improve the outcomes, both financially and the health of your population. Number one is to control your own data. So the government has been very clear that an insurance company nor a pharmacy benefit manager own your plan's data. That data should be owned by the plan itself, the plan sponsor, and used by the advisor to maximize results. One way to maximize results, and you'll see, I'll give you examples of this throughout this presentation, is to make sure you're using even bigger data sets to benchmark what's going on in your population to make sure best practices are occurring. Then out of that, you will find opportunities. There are huge opportunities, both from a procurement standpoint and from a population health standpoint, that are sitting right in your data, critical in order to be a fiduciary, but no differently than everything else you do in your business, is to make sure you're measuring results. Very important, since the majority of the people on this phone are either a plan sponsor or an advisor working with a plan sponsor. Under ERISA, it's critical, and it gives you massive protection if you document the fact that you're going through this process. And this is a continual process. You're never done. So as a plan sponsor, as an advisor, you're continually restarting this process to make sure that you didn't lose anything that would be in the best interest of the participants of the plan. The other great news in healthcare, what's good for the participant is good for the plan sponsor. So there's perfect alignment on these issues. Nobody has to lose when you do this correctly. So why do you do it, right? Where we just went through a really brutal renewal season on stop loss, on insurance in general. Well, right off the bat, when you load data into a data warehouse with data analytics, opportunity will scream out of that data. So when you look at this, I'm giving you the most basic result you would find. In this situation, this client loaded their data immediately just by having the eligibility record, having the healthcare and pharma spend. We were able to identify in the data 32 people that were getting paid out claims that were not even enrolled in the plan. We also will find people that are enrolled in the plan not using it. All of these go back to your third-party administrator or your PBM as very intelligent questions that anybody in procurement would use. We just loaded a county recently in the Southeast. Right off the bat, they saved $500,000 because they had somebody in three people in end stage renal disease, and the TPA didn't count correctly. So they'd been in that situation for over 30 months. That liability should have went on to the government, where the plan sponsor was still paying out those claims. So just really we run about 120 different analytics against the loaded data that will really give you easily 3 to 5 significant things to work on. Now, one of the most often asked questions that I get as the CEO of Innovo is, can I do anything without real data? Okay. It's a very interesting question. So I actually worked with my team recently to lay out what are the major issues along the vertical that you should be able to solve for with data. Do I have the right plan design? Am I in the right network with the right insurance company? How is my pharmacy running? What's going on with stop loss? Can I buy things better than I'm currently buying them? Can I get ahead of the risk of my population to create a better outcome for them, less cost for me? Can I get financial reporting done? Can I hold this crazy system accountable? Right? So those are the things that you will do with data and data analytics. But the reality is you can actually do things with little to no data. So just to give you an idea, with a census, you can get directional data on how your plan design stacks up against a very significant, accurate database through plan design benchmarking. We now are able to due to the public rate data that's been required out of the carriers and hospitals, we can, with very little data, give you an idea of whether you should go deeper because you might not be in the right network. Once again, with census data, that gets a little bit better. On a number of these fronts, you can actually do a one-time data load if you can get that from your carrier or PBM. And then ideally on this data journey, you would actually start allowing a data warehouse to receive the raw data, to curate it, and then do all of the benchmarking comparisons so that your advisor can actually find that detail. A number of you on this call are the advisor. Data analytics in a self-insured plan is a table stake, not a nice to have. So that is where the world is today. 2 years ago, I might not have been able to say that strongly, but in 2026, especially after a really rough renewal year, this integrated data is critical to your success and the plan sponsor's success.
Hey, Hugh, we have a question.
Oh, awesome.
The question is, do you know what's happening with carrier data transparency for small groups, 50 and under, that are fully insured?
Yeah, it is the last to fall. So I wish I had better news. The intention of the law is it would go down all the way to the small group market. The reality today is the insurance companies are still hiding behind the fact that the employer isn't quote unquote at risk. So the specific underlying claim data is close to impossible to get. We do have examples in our 3,500 clients when we've actually gotten that, but it's truly a unicorn, still totally a special. I would predict in the next 3 to 5 years that's going to change. But I would also say that even without your specific claim data, there's a number of things a good advisor can do to benchmark in lieu of actually having the real data. So unfortunately, I don't have better news for you on that, but a great question. Okay. So in this scenario, and thank you, whoever asked a question, that makes my day. In this scenario, again, even a fully insured employer where you can't get the data, the beauty is that the government forced the carriers and the hospital systems to declare by diagnosis code how much they charge at their facility and within their network. So for the first time in American history, you can actually stack rank the different networks based on what I would call a Monte Carlo simulation where you don't have the data, which will give you a distribution of what claims would typically happen for a client your size and your zip codes, all the way through fully integrated data where your own utilization will go through this network evaluation to tell you what network you're going to want to look at really hard with integrated data to make a carrier move. In a lot of ways, this takes away what used to be called a repricing exercise. This isn't perfectly accurate, but neither was that. So this is something we work with the advisor community on every day. The next thing that you can do now with this public rate data and loaded data is we also are able to not only look at the network, and we do this with a number of UBA advisors, but there are certain procedures. The easiest one to talk about would be a knee replacement, where we have manufacturers that work with the advisors we work with that know every year they're going to have 5, 10, 20 knee replacements that will come off of their population. So using this data, you can see it actually lists out a number of disease states. And then based on which hospital system, it will tell you who's the least expensive for that given diagnosis. And then what we're able to do with that is then bring in the quality, third-party quality scoring for those hospital systems so that you realize, and this was actually a major lawsuit recently, New York Presbyterian, I'm not bad-mouthing anybody, I promise this is just purely data. For this procedure was the most expensive with the lowest quality ranking. So the lawsuit became, and actually the DOJ is now involved, that union tried to get New York Presbyterian out of their network with Aetna, and based on contracts, Aetna wouldn't let them out of the network, wouldn't allow them to take it out of the network, and the Department of Justice and Federal Trade Commission are now actively involved in that situation. But in this situation, you can see, not advocating for anybody, but if you look at it, whether it's Metropolitan Hospital Center or the Hospital for Special Surgery, you're able to get that at a significantly reduced cost at a much higher quality level. That's ideally that perfect alignment between what's good for the plan sponsor, what's good for the participant. And that's when you know you're doing the right thing. The reality in this situation is, as an advisor, you would do two different things. You would evaluate the network. In this situation, you might also consider one of these hospitals a center of excellence, potentially remove deductibles coinsurance if you use that hospital and that provider for the procedure, or like this other manufacturer I was talking about, they literally direct contract for X number of knee replacements at a fixed cost. That's called direct contracting. So once again, the beauty of data is this is really now you have consumer reports for healthcare, where historically the hospital systems and the insurance companies, you were almost completely in the dark on these issues. Hopefully that makes sense. Again, anybody has a question or I wasn't clear, just let me know. Okay, so as we keep on going down this path, it applies to almost every aspect of your plan. And I always try to remind people, like if you look at Starbucks, which makes a lot of coffee, they actually pay more in employee benefits than they do for the cost of the coffee that they roast. If you look at US Steel, they pay more for employee benefits than the raw materials to make steel. Okay, so this is a significant issue for everybody you interact with. So here's just a couple of really clear examples when we load that pharmacy benefit manager data. Here's the difference between AviQ or an EpiPen, right? So as you look at that, although the market pushed everybody into AviQ, the EpiPen does the same exact job. It just doesn't read you the directions. And that would save you significantly on the cost of that device. Same with, this is metformin. Now, there's been a lot of change around diabetes drugs. But if you look at this, taking 2 500 milligram pills would be a significant savings over one time-release pill of 1,000 milligrams. So if it's not completely medically necessary, for the good of the plan and the good of the participant, you're going to want to get them to that alternative drug. A good PBM is doing that every single day. That is data that you're going to want to look at to see what's going on with the formulary and the services within your PBMs. This is a great example, and this is a real example. So depending on what PBM you're working with, they're either going to introduce biosimilars or they're not, right? So here we have a client on the left that's working with one of the traditional PBMs. They have a less than 1% penetration on the use of biosimilars. On the right, you have a more progressive PBM. They are using biosimilars. They still have over 50% working with Humira. The reality is, even net of rebates, this saved this client $1.2 million. So this is something that's very obvious when you load data, and it actually rationalizes one PBM over another. Okay? All this is available to you in the self-insured market. The other thing that I've heard, I'll just kind of talk to myself and ask myself a question, but when you look at loading data, I just had this on a call earlier, people will still say, well, it's impossible to get self-insured data out of the carriers and PBMs. Just last year, my firm loaded over 1,500 new employers. There are two situations when we didn't get data out of over 1,500. And it wasn't because the PBM or the TPA wouldn't give us the data. It was that they're so bad at adjudicating claims that the data was useless, which tells you a much bigger issue for you as an advisor to evaluate. So just trying to load data will actually tell you the quality of the carriers and PBMs you're currently working on. But that's a total exception that you actually can't get data. I would say the new game, which you should never tolerate, is exorbitant fees charged by the PBM or carrier so that you give up on loading data. I would tell you that's a fiduciary breach. And honestly, most of the advisors we work with are able to negotiate away those fees. Okay. Just trying to give you a couple of things to sink your teeth into. So when we look at this, because I want to make sure everybody on the phone can take away something real, and I'll break this out. We kind of went through, if you would, that procurement accountability wheel a little earlier. Just want to give you like in real life, and then I'm going to show you specifically at the end what best practices look like. But if you look at this, it all starts with the underwriting level. Can you actually stratify the risk in your population? Where are the opportunities to create efficiencies? This is also an interesting time because whether you're in a captive, whether you're using stop loss, the only three people on the risk are the employer, the employee, or the participant, and the stop loss company. All of you actually need to be looking at the issue exactly the same way. Then working with the advisor, the relationship managers, you're going to identify through the data, the technology does this for you, not a broad communication, but what subpopulation very specifically has that risk, or you can create efficiencies for. So this is very much targeted, not just a spray and pray approach. Then you're going to look at what are the opportunities. There are very basic ways to identify this. So I'll just give you an example. We were working with a school consortium, and they were with one of the Blues. Just by putting a pre-authorization program in, where did you get the injectable drug done? Moving it away from outpatient hospital to your doctor's office or to your home, that saved the school system $1.2 million. They didn't have to move carriers. They didn't hire a third party. They just used a program that was already available to them from the Blues. Okay? You implement that solution, like I just described, you have to measure it to make sure it's working. So there are many point solutions being used today that don't work. Not necessarily even the point solution's fault, but people are paying these additional PEPMs, and there's actually no evidence in the data there's a return on that investment. There are also point solutions that are saving huge amounts of money and making people healthier. So you really just want the data to get in the way of the story. So this is about accountability. I just want to show you very clear examples. So in the data, once you load the client's data, or you are the client, you load your own data, there are analyses that you can easily do with technology to understand exactly where the gap in care is. So what you're always trying to do is try to figure out in a population who's actually adherent to the protocols to deal with that disease state and who's non-adherent. Okay? So the whole population is the population. In this situation, if we're dealing with diabetes, the subpopulation is those that are pre-diabetic or diabetic. And then we're looking for the people that are non-adherent to the appropriate protocols because they're huge risk to your plan. They're also a huge risk to themselves. Okay? Then what we're going to do is we are going to look at what is the implication of the non-adherent diabetics. So we look at, this is a real life situation, by the way. So we look at all members. Their medical cost per member is not too bad. But if then you look at the pre-diabetics, it's more than double. And if you look at those that are now diabetic, it's more than triple. Okay? So what we want to do is say, if we're able to intervene through a third party or through your core program, and we can keep those pre-diabetics from becoming diabetic, that would save the plan $124,000. If those pre-diabetics become diabetic, that will cost the plan $250,000. This can happen on every disease state. And then you want to work with your TPA, your PBMs to make sure somebody is acting on this. More and more, depending on your insurance company PBM contracts, more and more advisors are actually giving that intervention program access to these dashboards where, without the employer seeing the specific member's name, the intervention program can and reach out to that person to engage them. Once you engage them, it will be critical to measure the results. And that's where you realize whether what you're doing is having an effect or not having an effect. And then you check and adjust either your strategy, or you get rid of that point solution, or when it's working, you double down on the technique because of the alignment on what's good for the plan is good for the participant. Okay, so one of the biggest areas, because data can be really intimidating, right? Technology can be really intimidating. I was just speaking with Elizabeth from UBA before I jumped on the call, and we were talking about technology, right? I run a technology company. Technology can always be good for, like everything, for good or evil. One of the most intimidating things for an advisor or a plan sponsor when you look at data is, how do you interpret data? The beauty of technology, and in this situation, we have to make sure all the technology is behind a firewall. So none of this is public information. But once you secure the technology and you apply AI to a very complicated subject, you are able, with a hit of a button, to give an executive overview and a conclusion that allows the advisor and the plan sponsor, along with their vendors, to align to how to get ahead of this risk. And as you can see in this dashboard, it gives you a lot of different disease states and just kind of where does your specific data stand versus a Novo universe, if you're in a certain part of the country, based on other people in that part of the country, if you're a specific size, specific industry, all of those you can benchmark yourself against. And that's what you're going to want to do. I
Thank you.
think
We've
there's a
got a question, if you
question.
don't
Yep.
mind me interrupting you.
No, that'd be great.
This is from TJ Bullock.
Hey,
First of all,
TJ.
he says, great stuff. And he's asking, when you're marketing to fully insured employers, how can Novu help? And specifically, what data do you need to uncover insights that prospects typically haven't seen before?
Yeah, so I think there's a lot of tools, right? Like I know at the UBA conference, I always forget their name. I mix it up with like three others, but there's a way to give census data and it projects out what the move to a captive or self-funded would look like, right? I would say if you look at that grid, TJ, more than happy to share this presentation if I think it's going to be recorded and sent out to you guys. That grid is really important because due to the fact that the fully insured carriers won't give you a lot of data, we're going to really be left with the census and the plan design, and then really benchmark like crazy in lieu of being able to do the very specific diagnoses I'm showing you now. So we'll work with you, we'll work with UBA, make sure all the partners that can help on fully insured are aligned. There's a number of things we can do for you, and there are other partners that can also look at, is it time to change funding type or stay right within fully insured, but then make sure plan design is maximized, benchmark to make sure cost is appropriate. So really, when you have less data, you're stuck purely with benchmarking. The more data you have, you can really be prescriptive on how to have a major impact. Hopefully that makes sense, and I appreciate the question for sure. Okay, so one of the biggest things is all of this can be incredibly overwhelming. So one of the things we've been working on with UBA firms is to actually lay out, if I was looking at a 1-1 renewal, this isn't gospel, by the way, but this would be, if you're as old as me, they used to call it, if you didn't want to read a book and do a book report, they called it the Cliff Notes. I'm sure it has a different name based on your generation. Now I think they call it ChatGPT. But the reality is, every quarter in your calendar year up to your renewal, there's a very specific procurement accountability process that should be going on. So this just gives you an example of one of them. Anybody that wants to take this, discuss it with me, more than happy to do that. My team is very much up to speed. But if you look at Q1, right, you just had your renewal, you're going through the beginning of that process all over again. This is when you look at, again, the results from the prior year, and you start to then look at that data, your contracts, and then in Q2, which we're almost getting to, then you start looking at, is your strategy really being met? Are there better ways to accomplish it? Do I have an underperforming vendor? Am I comfortable with my approach, and would it meet a fiduciary standard? Again, separate discussion, but with UBA, we can bring you up to speed on being a fiduciary. Then I list out for you guys all the things with loaded data that we would have dashboards for you and the sponsor to evaluate. Third quarter, you start to finalize selection, contracting. Obviously, you're getting into open enrollment. Again, there's a list of things with data you would be looking at. Q4, we're now going back to the beginning of the process, and we start doing all those comparisons, the ROI analysis, and calibrating what we're going to start looking at in Q1. So when I say a procurement process or a fiduciary process, it is always a check and adjust, especially in this industry, where this industry is famous for moving the margin around, right? I'll just give you a clear example. When I took over Innovu, the number one disease state and expense in almost every plan was cancer. 7 years later, the number one expense is typically musculoskeletal. That has become a real profit center for the hospital systems, right? Something you're going to want to take a look at. So that's not meant to be gospel right there, but I want you to understand that this should affect the account management strategy of your annual calendar with the plan. Hopefully that makes sense to you guys. And then at the end, I just want to say to you guys, the takeaways are pretty basic. Make sure the plan owns its own data. That way, if you need to move, you don't lose any of the trend analysis based on previous year's data. And any fiduciary should own their own data. That's very foundational. Definitely use it for the procurement and accountability process. And then at the end of the day, I always say this as a guy that's been in fiduciary for about 35 years, which, if nothing else, makes me old. But the other thing that you want to do, the advisor and plan sponsor, you want to end every meeting by saying, we're using a process, we're documenting a process that proves whether we were right or wrong, we were always intending to work in the best interest of a participant. If you do that, you'll make really good decisions that will be good for the plan, the employer, and the participant. And you will also meet the fiduciary standard, which more and more is a major topic of discussion in employee benefits. So hopefully within that time frame, and for a big blowhard Irish guy to get through it within the time frame Haley allocated to me, she's probably as shocked as anybody. I hope that gives you a feel for kind of the rhythm of incorporating data, benchmarking, process, transparency into your practice, because we are in a total flight to quality. The advisory teams that do that will grow. Those that are hoping this goes away will shrink. I feel very confident. That's not just because I'm in the data business. And with that, Haley, I'll flip it back over to you.
Yeah, we did have another question. This is from Chance. He is asking, are you seeing any proactive movement or steerage to functional healthcare versus symptom treating healthcare? I think is what that's supposed to say. In other words, perspectives providing resources and data around health span, longevity, regenerative medicine, and or epigenetics.
Yes. Yeah, I again, a lot of really big words for me, right? So you'll have to bear with me. I'm sure my clinicians and data science would be all over it. So you'll just get my perspective more and more, just to give you an idea, not only are we AIing dashboards, but we actually are getting into not only predictive risk, but predictive actual disease states and drugs that will be taken in the future. So I just when I was listening to that question, more and more that predictive is driving, pharmacogenomics and other areas that are getting ahead of the risk, not just looking backwards and projecting that forward. And that's the other beauty of technology. I mean, that the amount of calorie burn to do that a year ago was almost, you couldn't do it. Today, probably every month, that ability gets easier and cheaper to do. So, yeah, I would say would love to square you off with the right people in my organization, but we are collaborating with a ton of the point solutions without getting paid by them, where we can identify exactly what subpopulations they want to square off to, I believe, accomplish exactly what you're talking about. Yep.
Thank you. I don't see any other questions in here. I know it can usually take an extra couple of seconds to type a question.
Yeah,
But if someone does think of something afterwards, we are always more than happy to try and answer for you or get Hugh or his team involved. So always feel
absolutely.
free to reach out. But with all that being said, I want to thank Hugh for sharing your wisdom and thank you to all of our UBA partner firm employees and any of their clients who joined us today. We do hope to see everybody at our next employee benefit webinar, which will be on April 21st. So we look forward to seeing you then. Thank you and have a great day, everybody.
Thank you, Haley. Thank you, everybody.